Thank you. I was so excited that I forgot to welcome you. So, welcome. I would like to talk to you about palliative care in Latin America, the most recent advances that we've made. I would like to tell you that perhaps this is not true because the palliative care in Latin America are somewhat dynamic, that services appear, disappear. So it's very difficult to take a picture, an unblurred picture. So this is a possibility so we can improve things. And if you have any comment, you could send it to us before we publish this. These are preliminary results. So instead of getting mad at me, please just send me a small note with the suggested changes. To begin, this is a very short movie. My brother told me that when I showed you, even this is a picture of all of us. This is to think that this is palliative care has to do with all of us, as well as death. We have the demographic transition in Latin America. There is a transition demographic. That means that the older population is continuously increasing, and this increase in population is much faster than we've seen in Europe. In Europe, they said, oh, Latin America, you're so young. Yes, we're very young, of course. But most of people are dying over the age of 60, 70, and that growth will continue with an increase in chronic diseases, and where systems are not prepared for this new so-called tsunami. And the epidemiological transition also. We are becoming ill with chronic diseases. This is information from WHO. And here I made the calculations of non-transmissible diseases. Death by non-transmissible diseases in Latin America are more than 75%. Of course, we have infectious diseases. We have other needs. People who are dying in Latin America, 75% with chronic diseases. People who are going to require palliative care. Excellent news. In every Latin American country, there's some palliative care, and this is very good. With greater or lesser progress, but all countries are doing something. It started in 1980 in Colombia and in Argentina with Dr. Benck. And the emergence have been quite rapid. We have seen several services which shows this progress. But we also have a great need. Calculating 60% of death would require palliative care means that approximately 3.5 million people will be requiring palliative care for 2016. More than 3.5 million people need palliative care. And these are the ones who die this year because we have palliative care not only at the end of life. Those who don't die, also WHO calculates twice the number. And we know that for each person who dies, there's at least 8 people around them, family members, relatives, who are also being affected. These are estimations. We don't have hard figures of those needs, and some go from 80% to less, but just to have an idea of the need we have. And the possibility to offer palliative care from 2015 is what being calculated from quality of death index, and for Latin America, and the capability to offer palliative care is approximately 1% for all Latin American countries, which changes among different countries and changes, of course, within each country. This graph is very nice because it shows the demand for palliative care, the provision of palliative care, and we see how in yellow I show you the Latin American countries. Most have a low demand, but also the provision is low. This, with the socio-demographic changes, is going to shift towards my left. And of course, we have to increase service provision. With the data from the Atlas, the preliminary data, we found that there's approximately, we reported 1,158 services in Latin America. Most of them are in the hospitals. More than 50% are reported in the hospitals of palliative care units or mobile units. Some of them have home care or in the hospital or outside the hospital. In dark, we have the countries who have more than 10 services per million inhabitants. In orange, from 5 to 10 services per million inhabitants. And the pale colors have less services. In total, 3.4 per services per million inhabitants. And pediatrics, less, 0.2 services per million people under the age of 15. Well, this is a lot, it's little. It's much more than what we had the last decade. So the EAPC suggests 50 units of palliative care per million inhabitants. So you can see. These services are not distributed uniformly. Most 43% of those services in this region, of those 1,000 and something, are in Chile and Argentina, who have 10% of the Latin American population. The other 90% are sharing almost 60% of those existing services. So this is a heterogeneous distribution inside the region. In terms of medical education, in blue, there's 100% of medical schools. In blue, those who have palliative care as a mandatory or an independent course, sometimes mandatory, sometimes optional, but it's independent. And in red, you can see those who don't. Those are the physicians and people that being trained in medicine, future physicians, and are not getting any training in palliative care. All those in red don't have any training in palliative care. We have heard before what that means. Most of patients will benefit with a training at this level. This is 6% of the medical schools of the region. 6% of the medical schools in the region have palliative care as an independent course. And postgraduate training is not that good either. In green, we see those areas or countries where they have a certification, a diploma course for palliative care, but there are countries who don't have not even a diploma course or a certificate in postgraduate training in palliative care. And in blue, those who have a specialization or subspecialization. And here I must add that in Chile, at this moment, they're starting to work on subspecialization, and countries such as Paraguay also have a fellowship in different systems for care. There are countries like you see in Central America where postgraduate training is quite limited and low, and I know that major efforts to improve in this regard. And this is serious because 413 teams in the entire region, we see that the physicians who care these palliative care units, 60% of them have some type of training in palliative care. It may be from one online course up to a specialization or subspecialization. So that means that 40% of physicians who work in the palliative care unit have no training. And here we need to think in terms of availability for these units. So these are macro indicators that doesn't speak about the quality of healthcare, the value, but just the quantity. We know that the levels of care, a small percentage, 5 to 10%, will benefit with specialists, but we have deficit in training of palliative care specialists. We have a deficit in the training of the middle level oncologists, pediatrics, geriatrics, intensive care physicians who are working with patients who need palliative care. And we have a deficit in training, undergrad training, that will benefit with this training. For 60-70% of people have this need. In health policies, we have increased. In red, we have those countries who have a program or a national plan. In blue, those who have a national law. And in light blue, countries who have, in some of their laws, some type, or they mention palliative care. You're going to see outside the posters with each country is represented. This is just a summary. In the opioid consumption, we have increased dramatically in terms of strategies. Countries such as Argentina and Colombia that will be presented during this event. And some continue to have deficits in the opioid consumption. 6 in the red line, 6.7 is the Latin American median, but the global median is 61.3. There's been a lot of improvement, but I didn't put it in this line because we couldn't see this graph clearly. This is for 2015. So we asked for access to morphine, about the cost of essential medication, off-patent or morphine. And I asked to my colleagues of different countries, how much do you have to pay in your country for one tablet of morphine, following the process by Dr. Roberto Wen? How much would it cost to calculating 100 milligrams per day? This is just data for research. We know that this changes. 100 milligrams per day for 30 days. What will be the cost of morphine? We see that, for example, in Honduras, somebody will have to work 73 days. If it has a minimum wage income, they will have to work 73 days in order to pay morphine treatment for 1 month. And we know that many people are jobless and that morphine is just one of the medications required for people who are requiring palliative care. And go to countries like Panama, 45 days, El Salvador, 25 days, and in red, other countries who don't have oral morphine. No oral morphine available. The cost of injectable morphine are even higher than oral morphine. However, many countries don't have it available. Venezuela is not shown here because there was no type of morphine available in Venezuela. It gives us some thought. What are patients suffering? Because the disease is present and advanced disease is present. Many people come in advanced stages, as Liliana mentioned, and perhaps they cannot afford and are not going to be treated. I have modified the ALCP indicators by selecting just one indicator of the different pillars of palliative care, which are health policy, education, service provision, and medications. And we have included a national plan for palliative care because this is a law that covers us, but the law needs to be implemented, enacted, and that just works on paper. So we look at the health policy, and in the health policy, and then we'll go into education, the percentage of medical schools who have palliative care, the number of palliative services per million inhabitants, and the consumptions of opioids per capita in milligrams of morphine. With this, in 2014, we had this distribution. 2014, I made the calculations with new data, and we see a major change, especially because there is a flattening. Well, what do those dots mean? What do we mean inside the region, how those countries relate among each other? These are not absolute figures, but there's a relation between among the different Latin American countries, and this flattening means that many countries have become homogeneous, like an elevator phenomena. Some countries have risen, and some other countries, like Uruguay, that have been a major leap in relation to the other countries from the region. The R square, 0.8, means that most of countries preserve their positions, but not all. In terms of a country compared to another, there's a different development of palliative care. Countries with higher development, Uruguay, Argentina, Costa Rica, and Chile. And those numbers are not absolute, just categories. And then with a median development somewhat lower in relation to the other Latin American countries, we have Peru, Dominican Republic, Bolivia, and Honduras. The countries in color, Guatemala in green, because they improve, they change category. And Peru also changed its category. And when we talk about rich countries, I made a calculation of this index distribution in relation to countries' income, and we see that this is reproducible. The richest countries have the best development. The poorer countries have less development, but we are Latin American, we're all Latin American brothers. So, what are the challenges we have to face for palliative care? Well, the challenge, as Felisa meant, to close the gap. And this gap means that we need palliative care for everyone. And I'm going to say, why everyone? Well, for all diseases. Like Scott Murray mentioned, for all diseases, not only cancer, as somebody mentioned. Not only for cancer, but other non-oncological diseases that we need. At different times in life, not only at the end of the life when people are dying, but throughout the disease process, people are not being cared for in different areas, not only at home, hospital, different places where people are living. And for different groups, we have children, we have the refugees that are moving from one country to another, who not only bring their social problems and suffering, but also chronic diseases that are unattended, the indigenous population, the elderly, people with other sexual orientations, people who are in jail, many vulnerable populations that we still don't reach. And it's different dimensions, because palliative care is not only pain, not only symptoms, but also there's other aspects that need to be considered. For example, the psychological aspect, the emotional aspect, and the existential aspect, which are also important to consider. Challenge, education. I'm a teacher and an investigator, and this is extremely important for me. The first level of care, the palliative care, are in the hospital, when I showed that 70% could be managed at home. The access to essential drugs, as we mentioned before. And here I would like to emphasize that we call essential medications because they cannot be missing. That's what we call essential medications. And the commitment of the stakeholders for these activities are here. Civil societies present here, authorities, health professionals, health practitioners. This is a commitment that we need in order to develop palliative care. And that's a challenge. And of course, community as a whole. We need to involve the community, and there are excellent examples throughout the region of compassionate neighborhood or neighbors. To conclude, there are major progress made in the development of palliative care in Latin America, and this is excellent. I'm very happy. But there are large inequalities among countries and within countries. And my conclusion is that we need to develop comprehensive strategies that involve education, health delivery, service delivery, access to medications under a health policy. This is a definition that I have been having on for 10 years. And the same conclusion that I hope someday I don't have to put this statement here when I talk about palliative care for Latin America. Thank you very much.